had Dr. McNeil, and he talked about how to do an x-ray, how to interpret an x-ray a little bit, kind of how it all works. So that's kind of a good introduction. My job is to teach you how to read a chest x-ray today. So we're going to talk about that a little bit. So for you that are not spatially aware, this is a little difficult, okay, because you're seeing something that's really flat and just an image, and you have to think about it as a 3D image. So the biggest thing about taking an x-ray is, and looking at an x-ray, is you have to come up with some type of systematic approach to it. Because you're just going to look at it and you're going to see an image, okay? So it's like looking at a picture, you see the face and you go, oh, my kid's so cute, or oh, that was a beautiful waterfall. But what you need to start doing is looking at all the little details on it. So you have to find a systematic approach to look at an x-ray, okay? Or you'll miss things. You'll look at the lungs, but you'll miss the fracture, or you'll miss the heart problem, or you'll miss something that's going, actually a problem that's going in the abdomen. So systematic, you got to think, and I don't care what approach you use, but just, you have to come up with something. I wrote this on the board because this is just there's A, B, C, D, E, F. I mean, it goes on and on, but I think A, B, C, D is an easy way to think about it. This will make sense as we talk. But it stands for airway, bone, cardiac, and the diaphragm. There's a lot more to a chest x-ray than just that, but it's a good way to start thinking. So when you look at a chest x-ray, first of all, and hopefully Dr. McNeil talked about it, but make sure it's your patient. Okay? It's the patient that you're actually wanting to look at. So always look at the name. Because it'd be really bad if you've got the wrong person, and it happens. Because it's electronic, it's sent to you, and that can happen. So you can be looking at someone who is not even your patient. So confirm it. Right? So make sure you have the patient's name. You have to have the orientation of the x-ray. So what side's right, what side's left, okay? And you know which way an x-ray is taken of the chest? Did you talk about that? Right? So normally, for someone who's coming in for an x-ray, we get a PA. And you understand how that's shot, right? Through the P, the posterior, and the anterior is projected all into the x-ray. That gives us our best image. So someone who can stand up, we want them to be standing. And to take a good look at the lungs, you want them to take a good inspiration. Okay, there's reasons why you're going to have them, you're going to get two views, so inspiration and expiration, because you want to check to see if they've got like a collapsed lung. But for most chest x-rays, it's inspiration. And you want to make sure they have a good inspiration, because if not, you're going to miss some things. Okay? You want to look for things behind things. What does that mean? Well, the heart's not just the only thing in the chest. There's things that sit behind the heart. There's things that sit behind the diaphragms. If you think anatomically, your lungs aren't just straight across, right? They sit behind the diaphragms. Okay? And you never interpret an x-ray without a patient's history. Right? The patient's the most important. What they tell you and your physical exam helps lead you to a diagnosis. Can you find things incidentally? Absolutely. But our x-rays help us get to that diagnosis. Now, when you're looking at a chest x-ray, there are a couple things you want to know. Is the exposure correct? Is it the right penetration through that chest? So when I look at an x-ray, I want to be able to see the vertebral bodies. Okay, that's the first thing. If I can't see them, what have I done? Have I not penetrated enough radiation through, or too much?
Not enough.
Not enough. Okay. You want to look at the lung field, and you should actually see vessels going all the way out until about the last 1/3. Okay? If they're going all the way out, have I underexposed or overexposed? I've underexposed them. Okay? But you got to put that together with the spine. Because they may have something going on in the lungs that shows that they have white blood vessels. We're going to talk about the different terms. Going all the way out. It's going to make more sense in a minute. I know this doesn't make sense yet, but it will. So if I project a PA and an AP, first thing you got to know is what image did I get? But if you don't know, what you're going to see is if I project it this way, right? I'm shooting this way, and my film's here, versus this way, the heart is going to be a lot more magnified on an AP. Okay? And usually when you get an AP image of the chest, is because they can't stand up. So those are sick people. Those are people that are in a bed, in a hospital bed, and they can't stand up for you. And in a moment it's going to make sense, but it looks like they have an enlarged heart, and an enlarged heart tells us a lot on our chest x-ray. So this is a PA, and this is an AP. And I know this one because it was written on the x-ray. Your x-ray should all be labeled. Okay? And if your x-rays aren't labeled, you go to your rad tech and tell them to label them. Who's a rad tech here? Did anyone? I don't remember any of you saying that. But those, it should always be done. But this person has a lot of hoses and strings and wires and stuff like that, so this person is a lot more sick. And you can see that the heart looks bigger. And so this is an AP versus a PA. Now, when they're laying in a bed, you also can see there's not as many ribs showing either. And it's hard to take a big deep breath when you're laying in a bed. So if you look at, these are your posterior ribs here. See these flat ribs? I can see a lot more ribs on a PA versus an AP because it's hard to take a big deep breath laying in the bed. And they're sick. Your x-ray's always looking at you. So it's like the patient is looking at me when I put an x-ray up. They're always facing you. And I think Dr. McNeil probably said that to you, right? They're looking at you. Even a CT, it's like they're laying and they're looking at you. Down at their toes. They're laying flat. That's how the slices should be placed. Okay? The next one. Why do we take a big, deep breath? Why are we doing this types of thing? One, it allows us to see a lot. Okay, if I get those lungs really expanded, it lets me see pathology. If I don't, it hides things. Pneumonias, collapsed lungs, you don't see quite as good, especially if they're small. You may not be able to see little nodules as well. a pneumothorax, a collapsed lung. Now, when we talked about ribs, how do I know if I got a good inspiration? Okay, these are all things before I'm even looking for problems. I'm seeing if this was a good x-ray. Is I'm looking to see if I can count down 10 posterior ribs. Okay, can I count down 10? Is it pretty close? 1, 2, 3, 9, 10. So that's a good inspiratory. So there's 2 up here that are hard to see. Okay, you should be able to see about 6 anterior ribs. A good chest x-ray, you will see your anterior ribs, about 6. That's also a good penetrated x-ray. You see those anterior ribs. Posterior, these are posterior ribs. See how flat they are? Okay. Anterior are coming around here. See? You people that are spatial, this is good. People that aren't spatial, this is hard to visualize. We're going to talk about some pathology on Friday when you get a pneumothorax, why you do an inspiratory and expiratory. Okay? So here's an inspiratory of the same person and an expiratory. So I can't see 10 ribs here, okay? But I can see 10 here. So 1, 2, 3, 4, 5, 6, 8, 9, and that's the 10th rib right there. So that's an inspiratory versus expiratory. You look at the trachea, okay? The trachea should be midline. Should be midline. It may be slightly to the right, just slightly in people, but it shouldn't be deviated one side or the other. Because that means that I have something pushing it, a tumor or something pushing it over, or I have a collapsed lung, okay, that is now pulling that trachea over. And that's bad. So if we look down the left side, there's not much on the left side structural to see. Left side, right? You should get a good picture here. Here's our left side, right? Correct? Let me not confuse you. You should have the aortic notch and the left ventricle. That's what you're looking at here. And see, here's the trachea. See this black, okay? Or another term is more lucent. So when I use the term black, that's the trachea coming down. And see how that's midline. This person actually has something shadowing the aortic notch here, and it's pushing that trachea way over. Remember, trachea comes down and bifurcates into the right and left main stems. There's something pushing this trachea over right here. The other thing you look for is this person straight against the the plate? Are they rotated? Okay? Because if they're rotated, it may look like the trachea is deviated to one side or the other. And there's two structures that can tell me, that are equal on both sides, that can tell me that if they're rotated or not. What would those be? They're your clavicles, right? You can look at the clavicles and say, you know what? They're equal coming into, it looks like they're coming into the vertebral bodies, but they're equal from the middle of the vertebral bodies. So if you look at it, is the distance from the spinous process to this clavicle the same as the distance from here? And if it's not, you know you've got a person that's rotated. So it may throw your structures off a little bit. So clavicles are what we use to see rotation on an x-ray. I'm standing like this, it may make my heart look like it's shifted. Or it may make my trachea look like it's shifted. So I might say there's something wrong, and there's not. I need to have them go shoot a different x-ray. The right side, all you're going to see is the atrium. I'm going to follow it down, and all you're going to see is that atrium. And about 1/3 of the heart sits on that side. So if you look at this picture right here, as we come down, this is our right atrium. You can see the clavicles are close, so it's not rotated. And this person, here's the clavicle and the clavicle, this person is actually rotated. How do I know what's the right side and the left side? It's marked. That'll help you. Okay, so if you put a heart x-ray up, make sure that you have the right and the left the right way. But people can have a heart that's flipped, right? So you can't always go by the heart, right? Look for the gastric air bubble. The gastric air bubble is always on the left. So your gastric air bubble, which is difficult here, but it's right in this area. They're not great pictures to show you. Let me find one. I'll show you one in a minute. Don't get dizzy. But always look for that gastric air bubble. The other thing is what diaphragm sits higher? You're right. And why? The liver. So anatomically speaking, your right will sit higher than your left. So these are all normals, okay? These are normal things you're looking for. Size of the heart. If this is my chest cavity, okay, your heart should not be greater than half of the width. So if my heart's sitting right here, this should be less than half of the width from here to here. So if I take this and put it here, it's less than half. If it's greater than half of that width across the chest, that's cardiomegaly. That's an enlarged heart. That's abnormal. Can we use that on an AP? No. Can I use that on a PA? Absolutely, we use it all the time. In fact, if I'm using my picture up there, and I have electronic, because now it's all electronic, I will put my finger here and I will measure that heart every time. And I will put it, nope, it's not halfway across the chest. If I've got another picture and my heart sits here, I'll measure it and say, nope, not. Got another picture. I've got a heart that sits like this. I'll measure it, I'll put my finger on there, say, yep, greater than half. That's cardiomegaly, that's a big heart. I'll do that on every chest x-ray. That's part of my systematic approach to a chest x-ray. Because it's hard to tell. You can't look at it. You have to measure it. You use a ruler, I don't care. I use my fingers. If it's really close, get a ruler. So if you measure this, it's greater than half. Okay? So take your computer screen and measure it. Just do it. Do what I say, not what I do. So you'll see that it's actually greater than half. It's greater than half, that's easy. That's cardiomegaly. Next thing you want to look at is what we call the hilar shadows. Okay? This is the vessels, the pulmonary artery and veins coming out. The right is usually lower than the left. So you look at it, it's a little bit lower. If it's not, something's not right. Your vessels go out, right? And they should stop at what point? At 1/3. They shouldn't go all the way out. If they go all the way out, we've got fluid in the lungs of some kind. That could be infection, it could be congestion, it could be edema, it could be because of our big heart, and it's backing up into the lungs. But something's going on. Okay. Now you want to look at the lungs. Okay, you want to look at the lung tissue. Hard to see tissue, obviously, on an x-ray, but you got to think about it that way. Most missed pathology is in the apices, or the apex, because it's hard to see up there. You got a lot of ribs, you got the clavicles, you got the scapulas that distract you from that lung tissue. So either start there or end there, I don't care, but always look there. Tumors like to be there. Or the Pancoast tumor. Look at the vessels going out. Look at the tissue behind the heart. You should be able to see through that heart a little bit. There's some density that looks different there. There's something going on behind that heart. And then you're going to look for a pneumothorax. Always look for a pneumothorax. There's a pneumothorax. It's a collapsed lung, right? So the pleura has been disrupted and that lung collapses. We get air between the pleural sacs. So this picture's up here just for, I want you to start thinking about how the lungs look when you're facing someone. But you have what? How many lobes on the right? This is a big anatomy test. This is how you pass anatomy or not.
3 lobes on the right.
3 on the right, 2 on the left, with the lingula, right? I want you to think about this a little bit. So if we look at the lung tissue in this picture, if you start up in the apex and you look at this, it's definitely blacker, right? At the top, your apices are always blacker than the bottom. That's because if I stand up, where does most of my blood go? Where does most of your oxygen transfer happen? It's the bottom, right? You guys know this. Physiology, you're going to know this. This is where most of the transfer happens. Because gravity, it's tougher to get the blood up than it is to get it down. It's that simple. So my lungs would look a little wider on the bottom compared to the top if you just took an x-ray. Because water is more dense than air. Okay. So a little bit whiter versus darker here. Okay. You can see the vascular, this is the right hilar, comes out. A little bit lower versus the left. If you trace these out, they kind of disappear. You definitely see them here, but as they go up, they kind of disappear. They're not completely gone, but they're definitely not easy to track way out there. Don't really see anything out here. If you look on this left side, see this very significant line that shouldn't be here? That's a pneumothorax. There's nothing out here. That's air. So you have a collapse. You have a pneumothorax. There's a line there that shouldn't be there. Lung tissue. There's no lung tissue going all the way out. Is that easy to see? Do you see this line?
Yes.
See how it comes all the way up here? So I have tissue, I have a lung cavity, that the lung is in here. This is air, right? There's air there, where there shouldn't be. This one is, there's tissue coming out, there's blood flow coming all the way out. That's a pneumothorax. You always look for that line or a line. What's different about this picture?
The heart's really big.
Do what?
The heart's really big.
It is?
Infiltrates,
Do what?
infiltrates,
More opaque.
increase density.
It's more opaque. It's, remember we talked about that going all the way out to about 1/3? That goes all the way out. You really see that white opacity going all the way out to the end. What you see is, look at all this. That's fluid in the lung tissue. In fact, it's really hard to even see darkness at the apices. You see a little bit, but it's really filling up with fluid. Is this making sense at all, or is this just blowing your minds? With radiology or the test?
Yeah. Why do we do that for us?
Do what? This said what? So So when we talk about pathology, once you guys have had some of these diseases, this will make a little more sense. But remember, white lungs, there's something going on, especially fluid. Okay, you want to look at the diaphragms. They curve downward into a nice little sharp point. They shouldn't blunt. Okay, so my beautiful, beautiful drawing over here. This is the sharp point that I'm talking about right here. That's a sharp point. If they're rounded, fluid is filling up in there. So for some reason, there's fluid filling up in those angles. There's something not right. The right is always higher. You want to look for that gastric air bubble that's there. But what I don't want to see is air underneath a diaphragm. That is really, really bad. Because that means that I have perforated something in my abdomen. There's free air somewhere in my abdomen, like I've perfed my bowels. My appendix is perforated. And that air has moved up and is sitting under my diaphragm because I'm standing here. You shouldn't have free air in your abdomen. It's in your colon. And it comes out, as you know, as flatulence. It's not under your diaphragm sitting there. That's a really bad sign. In fact, that's a reason when you have someone with abdominal pain, you get a, part of it's an x-ray of the chest. Okay? You get it's abdominal x-ray plus a chest x-ray because you're looking for free air. This is a great picture of this right here is colon, okay? But see this free air? So there's air between the liver and the diaphragm. That should not be there. That is bad. And this lateral shows it great. Yeah, there's air in this tube here, in your large colon. Okay? But this is free air right here. Wow, you guys are dead. This is tough. All right. Okay. You have to have a lateral on your chest x-ray. Okay? Because I can't tell where anything's at by looking at something straight on. Dr. McNeil will talk about this. Right? Because if I take a picture and something's here in my chest and here in my chest, I don't know where it's at, right? I can't tell. My lateral tells me where it's at in the chest. It may look like it's in front of the heart, but actually it's behind the heart. It may look like it's in the trachea, but it's behind the trachea. Okay? That's the reason for it. The right diaphragm, okay, is higher than the left, right? We know this. And it extends from the anterior chest wall to the posterior ribs. That's how you know when you look on the lateral which one's what, and it's higher. The left is usually only seen from the posterior aspect of the heart to the posterior ribs. I'll show you a picture of that. So which diaphragm is this? By that explanation. anterior chest wall to the posterior ribs. The left is from the posterior aspect of the heart. Okay? So what one is this? So this goes from the anterior chest wall to the back. Because those are equal. There's not, it doesn't tell you which one's higher, right? They're both equal in height. Anterior chest wall to the posterior ribs. This is the right, this is the left, okay? It's hard to tell on this one, because there's not one that sticks way up, okay? All the way from here, and this one looks like it's coming from the back of the heart here. All right, on to the bones. Gotta look at bones. How do we usually get a pneumothorax? How would you think? I know you haven't had this lecture, but what would you think people get a pneumothorax from? A broken rib. Yeah. Trauma. So we definitely have to look at the bony structures. So look at the ribs. Look for fractures. Okay? People come in all the time for rib pain or chest pain when we do a chest x-ray for them. The sternum, tough to see, right, on a PA, but you can definitely see it on the lateral. So the way to really look at the sternum is by a lateral. Clavicle, look at your clavicle. The spine itself, a lot easier to see on a lateral, but you're looking for lytic lesions. Okay, you're looking for opacities in the bone. You can find a lot of tumors on a chest x-ray. So you definitely want to go through that systematically, whichever way it is. So if you look at your ribs, look at your posterior, look at your anterior. And if it's going from right to left, that's fine. And then look at your clavicle. Look at your scapula. So when we look at a lateral, so this is the heart right here. You should see a dark, right? It should be, or more lucent, in front of the heart or above the heart, right above the heart. It should be blacker or more lucent as you go down behind the heart. You should also look at the vertebral bodies. They should get darker or blacker as you go down. So this is an example of, you can see that behind the heart, these vertebrae do not get blacker. They actually have, there's an infection or pneumonia here. You lose that lucency. And so there's a pneumonia in the lower lobe. Right or left? Don't know. Because you just look, if we're just looking at the lateral, but we've lost that lucency or that darkness, blackness behind the heart. if you cut your, if you did a lateral, right? Oh, let me do it the way you're looking at it. I'm sure you guys look at this. It doesn't matter. So this is your heart, right? If you're looking at your lobes on your right side or left side, right? This would be what? Upper and lower lobe, if you're looking at it. That's how you would kind of distinguish it on a lateral. So, if my streaking was down here, where would my pneumonia be if we knew it was on the left side? It's a lower lobe, right? So we know something's back here in this lower lobe. If we, this is going to make more sense in a bit, but how is your right side, okay, here's your heart sitting in here. Actually, the way it's done is, this is your right upper, right middle, and right lower lobe. So in that picture, we know if we knew it was on the right side, because we would use our PA, we would know that that infection is in the right lower lobe. Okay? So when do we do a chest x-ray? When did we just do just a chest x-ray without any complaints? Obviously you do a pre-x-ray for anyone who's being admitted for problems. Okay. You do a chest x-ray with anyone who has a pre-operative. Okay, these are the recommendations for doing a chest x-ray. If they're having neck or chest. You do it when they have respiratory or cardiac problems. So if someone comes in with chest pain, okay, the chest x-ray is part of it. The patient who comes in with altered mental status, they may have an infection in the lungs. And we're talking about acute abdomen, chest x-ray is part of it. Anyone has known cancer, because you're looking for metastasis. Kids with belly pain, you're going to learn about this pneumonia. Can't tell you how many times kids with belly pain have pneumonia. If you could learn something today, you don't know how to read chest x-ray after this whole thing. But kids with belly pain, you better rule out pneumonia because they have pneumonia, more times than not. So at least put it at the top of your differential. A positive PPD, you guys will learn about tuberculosis. You get a positive PPD, you got to look at a chest x-ray to see if they're active. We're going to look at some active TB chest x-rays. Okay. Or if they work in something that exposes them to an occupational hazard, coal miners, obviously. People have a history of exposure to asbestos. We don't have it much anymore, but we still have those. You see the commercials all the time. CT scan. We do them if we find something on a chest x-ray that we can't explain. So someone comes in and you do a chest x-ray and you find a nodule, or you find a mass, and they don't have a cough, congestion, fever. Anyone with a widened mediastinum, I talked about this on Friday, but a widened mediastinum. You're looking for cancers, you're looking for a dissecting aorta, cannot miss. A chest x-ray, cannot miss. Spiral CTs are quick and easy. Take a big deep breath in, they can do the whole chest really quick. You find things really fast. So what do you need to know? We have a little lecture after, I have another lecture to go over real quick, it's the silhouette sign, but what do you need to know from this lecture? Well, you better know how to read a chest x-ray. Okay? And I'll tell you why. It's the most used radiograph out there. You will not order any x-ray more than you use a chest x-ray. And you do not have anyone reading your radiographs but you when you're out in practice. It's you. And you're the one that's going to pick up an aortic aneurysm that needs emergent now deal. That's an emergency. I don't know if Dr. McNeil talked about the one case that he dealt with, that it was a PA that missed an aortic aneurysm. Okay? And that was on a chest x-ray. And you're the one that's going to have to order these and interpret them and not get an x-ray back for a week from the radiologist that interprets it. So my recommendation to you, I know you look tired, and this is not like I'm lecturing you as children. It sounds a bit like it. My recommendation is there's a lot of sites that you can go to chest x-rays and just look at them, and it's not going to make any sense to you. And you come to me and I will go through all the structures with you. I have no problem looking at a million chest x-rays with you and saying, I don't see this, I don't get this doesn't make sense, and I will go through them with you. Because you've got to go over hundreds before you understand it. I promise you, you will use and use and use and use this. And PAs are really bad, and so are MDs and DOs about reading chest x-rays until you've been out in practice. But 3 years later is maybe 3 years too late. Okay? This is really important to me. I have lots of things that are important. Chest x-rays. All right, take a break. I'm not really lecturing. I really was. Kind of bad. Take a break, take a break.
What is it?
I've like told myself I'm not looking at people. Okay, not everybody like kill me at one time, but the grades are posted if you want to look.
Oh my gosh, why did you wait till I'm
Because
done?
people are freaking out.
Yeah, that's the reason we kind of.
That's why you got the
That's
fidget.
why we were so zoned out, because we were worried.
If I lose someone,
Well, if you're totally freaked out, don't look.
You want to go outside? Or like just go somewhere else?
It calms you.
I'm never scheduled to lose.
I'm just gonna go like no.
We didn't know that you had 2 lectures.
It's someone sure.
Is there any pictures on this test to like to be able to interpret these?
I mean, I passed that pictures on.
Okay. That's why I said that disclaimer, nobody kill me. Too late. Too bad.
I think it is.
They won't be ordered into like later at night. Activation or something. We feel
Sarah, do you have your phone charger? Let me see. That's usually does. I have 2%. I didn't bring more.
I do not.
Hey dog,
So,
do you have your phone charger?
feedback, right? Yeah.
You're an angel.
But it just takes. You know what?
I'm just gonna stress eat with the rest of it.
Taylor didn't fail physiology.
What?
I didn't fail physiology.
Yeah.
That's good.
Well, that's good.
I did the last test.
I felt one of them.
On this one.
Yeah, half of them. There's 8 questions. And 3 of them.
Look how small I had it open because I didn't want to distract anyone. I was like scrolling.
Did all right. You know, so,
Oh, I got 100 on Patho.
I got 100 on lab medicine.
I got an 87 on lab medicine. Yeah.
Oh, you're not.
These two are not going to fail. Crazy curtain. I knew people were going to either be mad because I told or be mad because I didn't tell, so I figured I'd just tell.
I knew as soon as
Oh yeah, it's like, I feel like in everyone, like.
Oh, me too. No, I was the whole time, and then it finally came up, and I was like,
I immediately started
Just
testing.
look at my concentration.
"What's that?" I said, "Oh, the boy squad got text. Okay, the girl squad got text."
I only care about the boys.
Yeah, we care about the girls.
Thanks for the text, bro.
Yeah, we gotta get Brock and Brady on our back.
Seriously, my bad.
I just had to find out.
Well,
It's okay,
I
that's how
knew
we
Larry
feel,
wanted
it's
to
okay.
know. I'm not gonna text anyone that I don't think would want to know.
Hey, Brock was right there telling me he does the same thing. He goes
Oh,
through
okay.
I
refreshes.
checked like every
okay?
10 minutes.
Yeah, I do too.
That's the first time I've ever done that, but I like kept refreshing.
Why do you look surprised?
I'm not.
Really?
Yeah, I beat the email every time.
Well, I thought the email would be coming like ASAP. I didn't know she had 2 lectures. Yeah, I didn't know that.
Now we can hang out.
She looked like I said I was at concentration. I just, oh my God, I was like,
Yeah, I know. So I was like, I walked out.
oh yeah, I can't pull it up there.
I need to go there, but I'm
Oh, that, if it's under the big line, it doesn't work. Did she send an email saying like congratulations or anything?
It's just going great. How's it going for you?
Oh, wait, maybe.
I'm ready for that.
Actually,
I'm not.
Good.
It's still like, I mean, obviously like not much better, but you know.
No, he's like, it's just like,
Really?
I missed
9?
Yeah, if I had missed 8, I would have.
What happened?
I think I have a pressure.
She was stupid question that, you know, like the blood cell. Yeah. They didn't think of it as 6 to 8. I just said, okay, 1 gram. It was 2 of them. Yeah.
Yeah, I was like.
It sucks like really bad because of 1 question. Yeah.
I mean, we don't want to go if no one else is going. So we're going to see.
I think I can get it.
No, they sound like.
Do what?
I think the average.
Yeah, I got an 8. So, fun story about this year. You know what surprised me on this? And I had no paint quite dry yet. Rangers, was the day with
I'm not gonna lie.
Man, my computer kind of got too. I'm batting 1,000 right
Did
now.
not know. Which one? It was like
I said my computer may die too. I'm batting.
No, it wasn't. Okay, good. I was like, but I'm like, was there?
My charger's in my bag.
Oh, is that what it is? Yeah. Oh, I thought it was
sorry.
conservation therapy, so I just assumed it's associated with. Oh, because it looks good though. But I thought that's from wrong. But so that, yeah. I just like, I couldn't think of what it meant. I was like, I see this word.
I missed the ones that I missed. Like I made 100 in Clem Ed, so I mean on some that I missed, I made like C's on sections, you know, because I missed like 2 out of 6, 2 out of 8 or whatever, you know what I'm saying?
That's on me last time.
Yes.
It's okay.
Okay,
I was like,
so this is the silhouette side, and it's the most important side you're gonna learn for chest x-ray. It's how you find stuff. It doesn't make any sense. I don't know why they call it the silhouette sign, but it is. It's called the silhouette sign. So, most of you, when you think of a silhouette sign, it's your, like, it's an image of you by a shadow, right? That's what you think of your silhouette. So this is the loss of a silhouette sign. Okay? That's really what it means, is the loss of your shadow, or loss of the shadow projected onto the chest x-ray. So, if you get blurring of a margin, that means that something is beside it, behind it, or in front of it. So those very specific areas that we're going to look at, okay, is the left heart margin, okay, the left heart margin, and that equals the lingula. This is really easy. The left diaphragm is the left lower lobe. The aortic notch area is the upper lobe of the left side.